Hey, it's me, Jen again, and today I'm talking to a doctor who focuses his ENT practice primarily on thyroid health, and he has a lot to say about Thyroid RFA. Coming up. Allow me to introduce Dr. Keith Forwith of Advanced ENT and Allergy in Louisville, Kentucky. Dr. Forwith and I tried on 3 separate occasions to have this interview, but we met some technical difficulties. But we didn't let that stop us from bringing you this video, and I really think you're going to enjoy hearing our conversation. Dr. Forwith has a high regard for thyroid health, and he's an early adopter of Thyroid RFA. Let's talk to Dr. Forwith about this topic that is near and dear to his heart, and stay tuned to the end where Dr. Forwith gives a really awesome piece of advice to patients who are seeking Thyroid RFA. You're going to be really surprised at what he has to say. Let's talk to Dr. Forwith. Finally, on this 3rd attempt, be able to actually have this interview. And I was so excited. You told me just a little bit about yourself, and then we got cut off by the internet. And so I've been really anxious ever since then to hear you finish telling me about how you got started in your practice and how you got to be more of a thyroid specific focus in your practice. So go back and tell me that story again.
Okay, so we had started doing ultrasounds in our practice, and I was in a fairly good-sized group of ENTs, and I kind of did my average fair share of thyroid operations in thyroid patients, but still I was pretty general. And we got a new machine in, and I wanted to learn how to use all the buttons that are on there. And so after clinic one evening, I had some time, and so I sat down to learn to use it, and I didn't have anybody there. I was the only one in the office, so I had to put the probe on my own neck, and there, sitting on my right thyroid, was a thyroid nodule. And I had no idea it was there, and my perspective changed. In fact, it was sort of a little bit of an emotional roller coaster for me, because here I had been diagnosing and taking care of people with this and talking to them, but I never had that feeling like I had that night. And I thought, you know what, I should share this. And so I made this Facebook post, and I should probably review my Facebook posts before I publish them. Because if you read it in a certain way, it sounded like I was saying I had cancer.
Oh, okay.
Well, all I was saying is I was facing the idea that I might have cancer.
Yes.
I wasn't trying to say that I had cancer. Yeah. I was just kind of going through, wow, this is the first time in my life that I've had to face this idea that I might have something wrong. I've been pretty healthy. And so anyway, I wrote this Facebook post, and then I started getting all these replies, and I hadn't even told my wife that I found this nodule yet.
Oh my goodness.
Yeah, and I was like, oh my God, people think I have cancer, and my wife doesn't even know I have a nodule yet, because I hadn't gone home yet. So anyway, it became very personal after that, because I had this perspective that just literally shifted. You can try to sympathize, I should say, with someone and say, I know what you're going through. But then when you actually have something really, really similar, like an unknown thyroid nodule, it's different. It really is, right? So I can empathize with people who are facing the nodule question. And then several years later, my wife was in the office for a hearing checkup, and we had the ultrasound out, and we're like, hey, let's just take a look at your thyroid. And there was a thyroid nodule. Unlike mine was an intermediate suspicion, which it has about a 10 to 20% chance of cancer. Hers was a high suspicion. It was 70 to 90% chance based upon those ultrasound findings. And, so that sort of was wide-eyed. We got her biopsy done, but then there was some extra testing that had to be done. And so literally we had a 2 to 3 week wait on those results.
Oh, that's so hard.
And she was either going to need an operation or not need an operation. And then, at that point in time, I'm like, well, we got to figure out who's going to do your operation. And I do a lot more thyroid operations than anyone in the vicinity. But do I do my wife's own operation? So A, was I willing to do it? And B, who did she want to do it? And oh gosh, so we talked for a couple of weeks, and literally she came back and she said, I want you to do my operation. I said, okay, let's just think about this for a while. Your results aren't back. And they came back the very next day, and she didn't have to have an operation.
Oh, how
Yeah.
wonderful.
Yeah. So, but anyway, I've been through a few patient experiences from the patient side. And through that whole process, I found that the more I dived into this, the more I was interested in it. And then I also really started to figure out how poorly some thyroid conditions are diagnosed and treated in the community around me. And so I ended up having sort of this crusade of education on parathyroid problems that are misdiagnosed, on Graves' disease, which is so frequently mismanaged, on thyroid hormone levels, where people are saying stuff and their providers aren't listening. They're saying my labs are this way, but this is not, something's not right, and no one wants to listen. And so anyway, I started getting more and more into thyroid and parathyroid, and it's kind of come to take over my practice. So it is most of what I do now. I still have a few other research interests and so forth, but that is the dominant part of my practice. And I'm very happy about it because, like I said, we need better sources of information, and some new things, which is why we're talking, come along and they need to be known. And it's sometimes really hard to get the word out on really new, innovative sort of things.
Yes.
Yep. As doctors, I will tell you, we all feel like we're well trained, and we all get into this sort of habit of doing things the way we were trained to do them, especially in surgery. So getting someone to do something different is usually a hard task if what they've been doing has been working for them.
Yes, I'm sure.
Yeah. So anyway, I could go on and on about that.
Well, I cannot tell you how much of what you said resonated with me, and I know it's going to resonate with so many of the viewers, because the fact that you can understand what a patient is going through, when I cannot tell you how many people reach out to me and they're terrified. They send me private messages on Facebook almost every day, and they say, I just found out I have a thyroid nodule and I'm terrified. And I understand, because I've been through that myself when I was first diagnosed. And so for a patient to be able to know that you as a doctor can identify with them on that you've been through that with yourself and with your wife, that is tremendously important, to a patient to know that their doctor really gets them.
Yeah, I will tell you though,
cool.
I do have my series of blunders, and early in my career, I had a patient that had a big family. In fact, she ended up being the 27th member in her family with thyroid cancer.
Oh, wow.
Yeah, they have a gene that makes them highly susceptible to it. And she elected to have me take out her thyroid and take out the entire thyroid, right? I mean, she was very, very scared. And so she had a nodule, and we had tested it, and we decided, okay, we're going to do the whole thing. We're going to take out the whole thyroid because of this family history. And she didn't have it by our biopsy, but she was scared to death and wanted it out. And so we took it out, and she had a 2 millimeter focus. Okay, 2 millimeters is really, really small. It was that same kind of cancer that ran in her family. And so I thought, well, this is the best news ever, because we got it out at the super early stage. And so post-op, I go bouncing into the room all happy, saying, guess what? Your biopsy comes back with 2 millimeters of cancer. I'm trying to finish the sentence about how early we got it and what great news this is. And I look over, and she is crushed. She is crushed. And insensitive doctor, right, wasn't thinking the same way she was thinking, because the fact that she had it also meant that she might have given that gene to her children.
Oh, okay.
So she was a step ahead of me with her concerns, and I've told that story often, because it's one of the reasons I hate talking to people over the telephone without video, because you can never see what's going on the other end. And I can't imagine how badly I would have blundered it had I not been in the room with her, right, and able to see that, whoa, something's really, really wrong. I've seen her children in the meantime. That family is up to 40 some family members with this cancer now.
Oh my goodness.
She's number 27. But, to your point, it is sometimes difficult for providers to be in that same boat with you.
Yeah.
Right? I hadn't thought about the children. I was just thinking about her. I didn't know what it was like to have a gene that has taken lives of family members. and then find out that you're in that same boat. Yeah, that's why we call it a practice medicine. Hopefully we get better over time, you know.
Wow, that's a tremendous story. I don't think I've ever heard of a family with that strong of a genetic tendency like that. It's understandable that you might, in that situation, not know exactly how to react, because it seems like it would be a rare situation. I'm curious to know, as you were describing about how you are very thyroid focused in your practice and how you feel like in your general area, there's not a lot of providers who are doing this well. To me, it seems like you're almost operating like an oasis in the middle of a desert because there's not anyone in your general vicinity who, as we're going to talk about Thyroid RFA, who's offering them. I think the next closest would be Virginia and Iowa and Michigan. And, there you are right there in the middle.
Yeah.
So tell me, because I know you were an early adopter of radiofrequency ablation, tell me how you came to the place where you decided, I'm going to do this, and I don't care if my colleagues think I'm crazy.
Yeah.
Tell us about that.
So I had already started on something where my colleagues thought I was crazy. I had gone out to Johns Hopkins, and I had learned with Ralph Tufano and Jonathan Russell. They helped me to learn transoral thyroidectomy, where we come in under the lip and come down through the neck, and we're able to do our operation without leaving any visible scar whatsoever. And I thought that was crazy the first time I heard about it. And then the more I listened to, in particular, Jonathan Russell, it was one of these things where doctors say, oh, scars are no big deal, right? But sometimes it is a big deal.
Yeah.
And it's not always just vanity. There are some people who just scar very badly. And I have a little scar on my neck. I don't know if you can see that on the video, but I had an inappropriate operation when I was in college. I had a lump there, and the doc said, that's got to come out. And after I went to medical school and got trained and had neck surgery, that never needed to come out. That was unnecessary. So I learned to do transoral thyroidectomy, and in the process of doing that, I got to know the guys at Hopkins really well. And they're one of the true early adopters of this. And through that network, I also got in contact with Leonardo Rangel from Brazil, who's a great guy and a great surgeon. And he also had done transoral as a new thing. And so I ended up in 2019 going to Brazil to work with Leo to learn to do this. And he was kind enough to allow me to do it on some of his patients. And he kind of stood over my shoulder and made sure that we were being very, very safe, and the patients had agreed for beginners to be able to learn to do this. And so I got to go to Rio and see some of that, and then do it that way. So I've always been on the edge of being an early adopter for things that I'm convinced are safe. And then the ultimate question is, what would you do with your family? Would you put a probe into your family's neck and shrink a nodule, if it was proven benign? And well, the bottom line is RFA is safer in just about every single way than surgery. Okay. Now, I pride myself on my surgical abilities. I do a couple hundred thyroid surgeries a year. My complication rates are 5 times lower than the national average, but I still have complications. Okay. I ran across this saying a while back that if a surgeon tells you that they don't have complications, then they're either too inexperienced or too dishonest to be your surgeon. Okay, so things do happen with surgery. No matter how skilled the surgeon is, it's always a possibility of that. And there are some risks with RFA as well, but those risks are markedly reduced. Maybe, and I want to talk to you about that in particular. Okay. So we know that one of the things about thyroid surgery is there's a nerve that goes underneath your thyroid gland. It travels down through the neck, around a blood vessel in your chest, and comes back up to the voice box. Okay, called the recurrent laryngeal nerve. But there's one on each side, and one of the risks of surgery is that nerve lies right underneath the thyroid gland. Okay, and so It's at risk whenever you do an operation. Now, is it at risk when you do a nodule ablation? And the answer is yes. But one of the things that's really important, and like when I heard the guys from Johns Hopkins talking about this, they go through great painstaking task of saying that not everybody is a candidate for RFA. Right? If that nodule is in a certain location that is really right next to that nerve, it puts that nerve at risk. Recently, we've had some reports of vocal cord nerve injuries.
Okay. That
should not be with RFA. It should not be. And I'm going to tell you why. You should pick nodules that are appropriate for the technique, that are going to be safe. Okay? If you're going to have vocal cord nerve injuries, it takes away one of the big advantages of RFA, which is that you don't have that risk. But if you introduce that risk, then all of a sudden, is it surgery safer or RFA safer? There has been a big swing towards people doing sedation with RFA.
Really?
Yes.
Like full sedation where they're completely asleep?
Sedation where they are sufficiently asleep that they don't have to, quote, endure.
Oh, goodness.
Okay. So, and
that's a problem when you're trying to monitor their voice, correct?
Well, and that's the thing, yes, is that there will be a change in the voice or pressure or pain or heat before there's any permanent nerve damage. But if the patient's asleep, you take away that safety net.
Yes.
And so I've had a couple of people who have talked to me about RFA and called back and canceled their procedure because someone else was willing to sedate them to do it.
Oh dear.
And it cost them an extra $400 or $500 to get the sedation.
Yeah.
But there's risk involved with that sedation, and you take away part of the safety we have with those nodules.
Yes.
The other thing that's also happening is, you should know, is that there are two companies in the industry that make RFA probes. Two and only two. And competition is always good for driving down prices and that sort of thing. One of them requires a very painstaking procedure to get ready to go with RFA. They won't even sell you a machine. They won't sell you probes until you've been through their courses. Back in November, I taught one of their courses. When I was done, I went to the company rep and I said, these people who attended these courses should never do this procedure.
Wow.
No.
Yeah.
It is not as easy as it looks. Okay. Yeah. But one of them left the machine running while the probe was still there and took hands off the probe and stood up and walked away, and the machine was still running.
Oh dear.
Yeah. And that's just that's a person who's sloppy, and that person was going to hurt patients.
Yes.
Right? I mean, RFA is wonderful, but here at the beginning, when it's getting revved up, we need everybody to do it safely so that in the end, we can argue to insurance companies and to Medicare and everybody else that it's safer than surgery and cheaper than surgery, which it should be.
Yes, I agree. It absolutely should be.
But if it's done by people who have no business doing it or who haven't put in the time to learn it, then we're going to see those safety things go away. It's not going to be safer than surgery. So there were some people there that had not done a lot of needle biopsies for nodules.
I've heard that skill can play into how well you do RFA.
Yep. In fact, there was an endocrinologist there. She had never done a needle biopsy, but she was very talented. She was picking it up rapidly.
Okay.
So we had a talk with her and we're like, look, you need to do needle biopsies, right? You need to do that for 6 months to a year before thinking about coming back for a little more RFA training. And she was totally in for that, right? She understood that it's a building process, right? You have to have a certain skill set before you develop a larger skill set. And she's going to do great. She's got really good hand-eye coordination. She's got really good hands. And she was meticulous, detail-oriented. These are all the things you need to be to do RFA well. And most surgeons are kind of that way to begin with. But anyway, the point I was making is that this particular company, they won't sell equipment to people who haven't been thoroughly trained. The competing company only requires you to observe someone else doing it. That's not the same. Watching someone do it, it looks easy. Doing it yourself, it's not as easy as it looks. And so the whole goal, of course, is to make it look easy, to be so smooth with it that you make it look easy. But the first time I saw it done, I'm like, oh, piece of cake.
Mm-hmm.
And then when you start doing it, you're like, oh, well, there's a few things here that you need to learn, right? There's a few tricks and a few techniques, and that's why you go to these courses where you get to do it first on cadavers. Well, actually first on chicken and gelatin. We ablate chicken nuggets that are buried in gelatin by ultrasound.
Interesting.
Yep, and then you do some cadaver work, and then you do patients supervised. It's like driver's ed, where you know how the person not in the driver's seat has a brake?
Yes.
Yeah, the instructor has the go pedal and can cut it off when things, because the whole thing with RFA, as you probably know, having been through this, you've got to be able to see that probe on ultrasound. Right? So, and I think in your case, if I remember right, you had areas below your clavicle.
I did.
And if you can't see it, you can't safely ablate that.
Right.
And so the stuff below the clavicle can't be ablated. You ablate the stuff on top of it. It, as you know, shrinks up, and then that other stuff gets pulled up, and now it's in a space where you can safely do it. But if you can't see the tip of that probe, it is not a safe thing to do. All right. And anyway, so there's some technique that's involved in a learning curve. But if we all do it well, right? Don't do it before you're ready. Don't do it before you practice. Practice. Keep patients awake so you have that safety margin. Then we should see that RFA beats the pants off of surgery when it comes to cost and safety. But sedation is becoming very popular.
That is so surprising to me. So in our Facebook group, we have about just under 2,000 members now, which is mind-blowing to me. And out of all of the people who have posted their story of their experience with RFA, I've only seen maybe 3 instances of a patient who went through the procedure and had a really hard time with the pain that they were experiencing during the procedure. And, you know, I attribute that to the location of their nodule, might have been close to some nerves. You know, some patients are given just a local lidocaine, while others are given local lidocaine and conscious sedation. And then there's also a lot of patients who have anxiety issues, and so they, you know, either preemptively are given by the doctor something for their anxiety, or they ask for something and they don't always get it. So, you know, I've not encountered very many patients at all who've really struggled. I remember one particular woman posted, "I will never have this done again unless I'm knocked completely out." But I'm guessing that she might have not had anything other than just the local lidocaine. So let me lead that into the next question. How do you do this procedure? Do you use just the local? Do you do the conscious sedation? Is this like an office procedure, or do you do this in more of a OR setting?
So we have up to this point done just local, and I hate to say just local because that sounds like it's inadequate. Okay?
Right. And I apologize. I don't mean it that way.
Yeah. But the nice thing about local is that there is no alteration of the mind. So conscious sedation, the key point is conscious.
Right.
Okay. And you got to be with it a little bit. So you can be a little bit relaxed, but you can't have it where the patient doesn't feel or is bothered by pain. And I will tell you that we do a lot of things under conscious sedation in the office, and we have an anesthetist that comes in and helps us with this. But some people are kind of loopy, and they're not going to tell you what you need to know because they just aren't bothered by hardly anything. So, and I could tell you story after story about operations where we've done where people are just goofy. You know, and you can't predict ahead of time how you're going to react to those anesthetics unless you've had them before. So there's always a little extra risk if you're going to do conscious sedation, and then the levels are really important because there's a degree, there's slightly relaxed, okay, and there is virtually entirely asleep. right? I mean, there are many people who will snore under conscious sedation.
Wow.
If you're snoring, you can't tell the RFA provider that things are going bad.
Yes, I absolutely can see how that is important. And
So
wow, I
light,
didn't realize that.
but light sedation is the most that should ever be used.
In my particular experiences, with my 2 RFAs, I had conscious sedation in place, but not in use throughout the entire procedure.
Mm-hmm.
And because my nodule was so large and it was kind of close to these nerves here, at the end, when I was starting to get fatigued and sore, I said, can we have the conscious sedation now? And so at that point, they turned it on. I was still fully with it, fully, able to say, ooh, that's starting to hurt, pull back. But I never would have said, I never would think that I was, not with it enough. However, on the day of my second RFA, I also had sclerotherapy done on a kidney cyst, and that procedure I was supposed to be awake for, and I was totally out. So I'm guessing the level, was up much higher during that procedure. So I can see how that would be a problem for you as a provider.
Yeah, and it's especially going to be a problem if somebody who's new to RFA, for
Right.
example, gives patients what they ask for, because frequently, I shouldn't say frequently, almost always we're asked about this.
Mm-hmm.
And I have to go through the reasoning of why we want you awake and aware. And again, you take somebody with a big nodule, there are times where you could be completely asleep because you're nowhere near the danger zone, right? It's only during certain parts of the procedure where you're near, and we literally call that zone, we call it the danger triangle.
Right.
When we teach the course on RFA, we talk about that anatomy. We talk about, well, how close is this nodule to that particular location? Because we want RFA to be safe,
Yes.
right? We want it to be adopted because it's safe. And so certain nodules in certain spots may not be great candidates for RFA.
Right.
Yeah, and it's not going to take, so I'll give you an example. My nerve injury rate for thyroid surgery is about 0.5%. Okay, so that's about 1 in 200. That's hard to beat.
That's pretty good.
But we need injuries at RFA to be 1 in 500 or 1 in 1,000. Right? You can't have them be 1 in 50. Then it's not as safe as surgery.
Okay.
It's really important, that this be brought in the right way, because a handful of injuries by one person will give RFA a terrible reputation.
Lowers the GPA, so to speak.
Yeah, last thing you want to hear is, oh, my best friend had that done and now she can't talk.
Right.
Yeah. So,
well, then let me ask you this question. In cases of patients who refuse surgery altogether, and or say they're not a good candidate for surgery and RFA is their only option, how does that figure into that line of thinking? Because I know there are a lot of patients who, myself included, who they just, for whatever reason, cannot opt for surgery. How would that play into that?
Okay, so let's just take worst case scenario. You're absolutely dead set against having surgery. And you have a nodule that's proven benign, and we like 2 biopsies to prove it benign.
Right.
So it's proven benign, and you want this taken care of, but I look and I said, Jennifer, this is a bad location. It's right next to your vocal cord nerve, right? But we're kind of stuck in this place. So one thing that we may talk about is not ablating right next to the nerve. We can still do quite a bit of the other part of a large nodule. And, most people who are looking at this have 5 centimeters plus on their nodules. You can still take care of 80, 90% of that nodule and stay away from that zone, knowing that you're still leaving some behind, right? You're not ablating the entire thing, but you can still get a lot of shrinkage. And then later, if that part grows, you can come back and treat it again, sort of like a weed that you would sort of trim down, and it's going to regrow if you didn't get it by its root. But in this case, maybe the root's right next to your nerve. I would talk through those sorts of options, and this is why you gotta, in my case, I always put your nodule on the screen. I always show you on the ultrasound, here's where it is, here's what it looks like. And you got to talk through these things so that people understand what they're signing up for.
That is reasonable to me. For your explanation was very reasonable. I liked that. So.
Yeah.
Myself included, there have been some patients in our group who have had RFA done at a location that is not in close proximity to them. And so they travel there and they have RFA, and then they go back home, and in the months following, they have their follow-ups done with a local physician who does their ultrasounds. And then they send those ultrasounds back to their RFA physician and consult via Skype. The problem that we are running into is that the local radiologist imaging people don't know what they're looking at, and their idea of what's happened is incorrect. For example, I had RFA done in July of 2019, and then in October of that year, I followed up with my local ENT, and he was very upset when he saw my ultrasound. He was saying, "Oh, this looks really bad. These borders are irregular. This nodule's very dark. All of these characteristics that are not good when you're looking at just a nodule." And I was explaining to him, no, that's actually what it's supposed to look like after it's been treated. But, he was not open-minded about RFA. And so that was the issue I had with him. But a lot of local imaging places, they're taking these ultrasounds and their measurements that they're showing are not accurate. It's like the physician who actually did the RFA, when they review it, has a completely different estimation of how much the nodule has shrunk than the person who has not been trained in RFA. Do you have a sense of where the disconnect is with that?
Yeah, I will tell you, this is a trouble with this being a newer procedure. Okay. One of the beauties of how the RFA works is that as you're ablating the nodule, you can see the ultrasound characteristics change.
Right.
That's how we know where we've ablated and where we haven't ablated yet. And exactly what you say is true. You take a benign looking nodule on ultrasound and you turn it into one that looks like a cancer. In fact, I warn patients about this all the time. When your ultrasound is done elsewhere, they're going to see things that really bother them. They're going to see characteristics which go into the high risk category. The American Thyroid Association has a very nice chart that breaks down ultrasound characteristics into probabilities of cancer. And what RFA does to a nodule is create characteristics which are in the 70 to 90% category. But what you have to know is where that nodule started to begin with. So it's why we should be insisting on 2 benign biopsies before we do an RFA, and why there has to be communication, because it is not yet known, and certainly the radiologist, so I'm ENT, had neck surgery, radiologists don't come to our meetings. That's number one. Number two, if you go to the ENT Academy meeting, which is the major meeting every fall, there is so much going on there that people like me go primarily to the endocrine section, thyroid and parathyroid. And not everybody in that special interest knows about RFA or RFA changes after this. We are currently planning the fall meeting for the American Thyroid Association and the Academy meeting, and I'm on both of those thyroid committees.
Excellent.
And RFA is going to be a hot topic this year. But I'm on a committee of a dozen other people that do exactly what I do a ton of thyroid work around the country. And there's only a couple of us who have done RFA, right? And so RFA is a hot topic. People want to know about it. But the answer to your question is that it is not well known what happens afterwards, okay? And so the radiologist doesn't know what a nodule looks like after RFA. It's just got to be communication, especially on these remote ones where you're in a completely different state and it's not practical for you to come back just to get an ultrasound, right? So that's the first thing, is that you got to be good communication. The second thing is you have to understand a little bit about thyroid nodules and ultrasound. Don't think of a thyroid nodule as a baseball. Think of it as a racquetball. Because what's the diameter of a racquetball? Well, if there's no pressure on it, it's going to be a round structure, right? But if you stretch the neck out some, it'll squeeze down.
Okay.
Right? And if you stretch it out more, it'll squeeze down anymore. Well, when that racquetball squeezes down, those dimensions change, right? And so you could make the racquetball look wider just by squeezing harder.
Mm-hmm.
In a soft nodule, you can change the dimension by patient positioning and even by the amount of pressure you put on the probe.
Wow.
So the most critical thing for RFA follow-up is volume reduction, not size. Now, volume is not as easy to understand as size. If you had a 6 centimeter and you follow up and it's at 4, and then later you follow up and it's at 3, it's easy to say, oh, 6, 4, 3, that's really good. It reduced in half. But in reality, that's not perhaps the case, because 6 centimeters is about the size of a tennis ball. 3 centimeters is about the size of a golf ball. If you think about the volume,
yes,
it's way different.
Yes,
it's way different.
Yes.
And so I like to use balls as a analogy. People come in with a 9 centimeter. I'm like, that's a softball.
Yeah.
Right? We're hoping to get that down to a golf ball. But even if we only get it down to a tennis ball or a racquetball, that'll be much better for what you got there. And that's a little easier to think about than just those particular numbers. So volume reduction tells you more than any particular number. And even the nodule that hasn't been treated can shift a little bit in a particular number because of positioning and that sort of thing. So think about that racquetball and how do you measure it and how much pressure on it's going to change dimensions. Does that make sense?
Yes, that's really interesting. And I had not ever thought about pressure making a difference in the dimensions. It just hadn't occurred to me as a layperson. Ultrasound is something I really don't understand well. I wish I understood a little better. Unless I'm looking at an ultrasound of a baby and I can make out like a skeleton, I have no idea what I'm looking at. So I'm always so amazed at the fact that doctors can look at an ultrasound and ablate a nodule and know what all the different things are that they're seeing. So that's just, I appreciate you explaining that. It's very interesting.
Sure.
Well, I've got one more question, and then I think we've got a few people in the group who have some questions for you.
Oh, great.
So my last question for you is, what do you think the future of RFA is? Do you see this becoming the standard of care for thyroid nodules? Do you see this being something that's going to be covered by insurance? How long do you think it's going to take for that to happen?
Over the course of 20 years or so, we do a lot of research, and I've seen other products come to market, get FDA approval, and the process is always way slower than you would like. And it seems obvious that, okay, you've got this thing, it's FDA approved, it's no longer experimental. And by the way, I say this all the time, if it was experimental, the FDA would not have approved it.
Right.
They don't approve things that are still being experimented on.
Right.
The whole point is you have to prove efficacy and safety before they'll ever get around to approving it. So it's not experimental anymore, and it's been done for decades in South Korea and Brazil, and so while it's new to the US, it's not new. So it will ramp up fairly rapidly because patients want this. When you talk about the safety of it, the reduced cost of it, and the fact, and this is probably the biggest one that people come in for all kinds of reasons, but what they should come in for is that they can keep their working thyroid and not have it damaged. That to me is the biggest advantage of RFA, but of course that's usually not the reason people come in. Usually people come in because it's an unsightly lump, or they're having trouble swallowing, or they're having trouble breathing when they lie down, or they can't bend their neck down and breathe at the same time. Those sort of obstruction sort of things bring in these bigger nodules that people want RFA for. But keeping your working thyroid, knowing what I know about all this, to me should be the number one reason for RFA. We always have to remove some thyroid that's normal when we do a thyroid operation. So even if we only take half of that thyroid away, there is a chance that you'll end up on a supplemental hormone.
Mm.
Of course, if we take the entire thing, you're going to end up on replacement hormone. And then sometimes people don't anticipate or think about the future. So somebody has a big nodule on the left side, and someone says, well, just take that half out. It's a safe operation, which it is. Years later, they develop one on the other side.
Mm.
Now they're going to be on a full replacement dose, which is never the same. Supplements aren't that bad. If you just need a little extra,
Mm-hmm.
the thyroid is working, we can get that to the right levels and people are okay with that. It's the full replacement dose that can be tricky for some people.
Mm-hmm.
But you have nodule on one side, there's no guarantee you're not ever going to have a nodule on the other side. In fact, multiple nodules are way more common than solitary nodules.
Mm-hmm.
So, and over time, I mentioned my nodule at the beginning of this conversation. It's at 1.6 centimeters, so I really can't feel it. It's not very big, and it's been there for about 12 years that I know of.
Mm-hmm.
Recently, I was teaching, and oftentimes I'll take my ultrasound with me and show my nodule and let my students see what their thyroid looks like.
Mm-hmm.
But recently, I have a second nodule.
Oh, okay.
It's tiny,
Bummer.
it's right next to the other one, but it wasn't there before.
Yeah.
And so I've got a small little nodule, which is fine. Hopefully it will stay small for a long time.
Mm-hmm.
But the good news is that if it does get enlarged and it's benign and I need to take care of it, this is a non-surgical way, low-risk way to do it. So I think it will be, whether it's 2 years or 5 years, I can't tell you.
Okay.
But it's coming. Okay. I mentioned the research. I did a lot of research on these steroid-eluting stents for your sinuses, and I have said for 10 years that this will be the standard of care, and it's getting there. It's
Okay.
getting, but not as quick as you would hope.
Mm-hmm.
But RFA will be the standard of care for benign nodules. It will be the standard of care for recurrent cancer in certain dedicated sorts of things, but I will tell you where the risk is on all of this. And honestly, for RFA's future, it scares me. People are anxious to do this on cancer. Stage 1 thyroid cancer cure rates are 99.7%. Why would you choose something different for now, right? Why would you give up your chance at complete cure for now, right? So RFA should be looked at only under strict research sort of things until we know for sure that we can get cure rates. Right now, we're guessing, right? We're guessing whether it's going to be effective for cancer or not. It's not proven. It's nowhere near proven, right? So why give up someone's chance for a complete cure for something that's unproven, right?
Okay.
So now that might be a little bit different, okay? If you have a bad heart and your lungs aren't safe to undergo general anesthesia, okay, now the cancer operation is really, really risky. So maybe RFA comes into play in this very limited sort of thing. But if you're super young and healthy and you've got 50 years ahead of you and you've got a chance for complete cure, I don't know, RFA, probably not the best option, right? Now, maybe a limited operation for that. So these are always hard discussions, but for right now, we need RFA to be what it is for benign thyroid nodules. And if we push beyond that too quickly, then again, the safety measures may come in.
Yes, I absolutely see how that's important, because we want this to be the procedure that becomes the standard of care. And so to ensure that, I can definitely see the need for being careful when you're choosing your patients and who's a candidate. Well, I really enjoyed all of your answers to everything that I've asked. Let me now ask you some questions from our Facebook group. Someone asks, well, I think you've already answered this. How many biopsies? You said 2 benign biopsies are required. And can molecular testing count as one of them?
Yes, it can.
Okay.
If it's favorable.
Okay.
Right.
So a patient could have a benign biopsy plus a benign molecular test?
Yes. So just a quick word on molecular test. The whole point of the molecular test is that they have proven to be as accurate as FNA that's benign to begin with.
Mm-hmm.
And to flesh that out just a little bit, if you get a benign biopsy from the get-go, like I had, okay, it is not 100% certain. The accuracy rates are 95, 96%.
Mm-hmm.
If you have a second biopsy, those accuracy rates go to about 99%. That's why we want 2 biopsies.
Mm-hmm.
Okay? If you get a molecular test that is favorable, you had an indeterminate, that middle ground, and they did the molecular testing and it came out as favorable, those rates are the same as the benign to begin with.
Okay.
95, 96%.
Mm-hmm.
Okay? So
Okay.
it's like having a benign.
Mm-hmm.
So a favorable molecular and a benign, or 2 favorable moleculars, you're an RFA candidate.
Awesome. And the same person is asking, do you use medication to help patients be calm during the procedures? I think this patient might mean something to help with just anxiety.
Yeah.
Not necessarily be asleep.
Yeah. And I will tell you, we have done some of the most anxious patients with RFA.
Mm-hmm.
And I think the basic guideline is this. If you are able to get through your FNA,
Mm-hmm.
you're able to get through RFA.
Mm-hmm.
We can pretty much predict how you're going to be with RFA by how you were with FNA.
Mm-hmm.
Now, I will tell you this. I do FNA markedly different than at the hospitals.
Okay.
So we do a little local. That takes less than 10 seconds, right? It's a pinch, it's a burn, but less than 10 seconds. And then literally we sit the patient down in a room for 20 to 30 minutes, and then we come back. So
Okay.
I go see somebody else, and then I come back, and now they're nice and numb. But
Mm-hmm.
numbness is 2 things. It's the skin surface, and it's also at the thyroid capsule.
Mm-hmm.
When that thyroid capsule, as you know from getting RFA, it has sensation to it. You can feel when things get poked through there, and when you just get the skin surface numb and not thyroid capsule numb, people can find it to be very, very difficult. So we do it, we take our time, we take a little extra time to do it. And you know the reason we do that, honestly, is because I had 2 FNAs.
Mm-hmm.
And I have a high pain tolerance, pretty high, and medically oriented. And I thought on that second one, I thought there's got to be a better way to do this.
Mm-hmm.
I was really uncomfortable. So we
Yeah.
started playing around with, well, how long do we wait? And 20 minutes seems to be the magic number. If we wait at least 20 minutes, it's pretty well tolerated by everybody.
Mm-hmm.
But anxiety on the table for FNA and anxiety on the table for RFA are very, very similar. So we have discussions after we see what their FNA reactions are. That's the easiest way to judge.
That's awesome. I like the fact that you take your time to help the patient be more comfortable. I've had 1 biopsy done without any lidocaine, and I got through it, but it was not pleasant. So,
Right.
Okay, let's see if anyone else has a question. Do you have any comments about a nodule that is pre-toxic? Pre-thyroid RFA, it's a cold nodule, but then after RFA, they have kind of a flood of extra thyroid hormones come into their system.
So anytime, and I think I know what you're asking there or what the situation would be. Let's first talk about toxic adenomas. They work great for RFA. RFA should be the procedure of choice.
Mm-hmm.
I mean, it's just, I love those cases because you can ablate the entire nodule and things are going to get better.
Mm-hmm.
Now, whenever you manipulate the thyroid, whether it's surgically, it's even true of radioactive iodine. And I'm not a fan of radioactive iodine at all.
Mm-hmm.
But you can get thyroid storm with thyroid surgery, and you can get it with RAI. And if you do RFA, there's a chance of whenever you squeeze or manipulate the thyroid, you can have release of hormone, okay, into the system.
Mm-hmm.
The storage form of thyroid hormone lasts for 3 weeks in your body. That might explain a little bit about so-called toxicity after the procedure, that if you do a lot of manipulation of the thyroid, you can get this surge of thyroid hormone into the system, and it takes a while to equilibrate back down.
Okay.
By the way, on toxic nodules, they should not be ablated while you're hyperthyroid. You should get your thyroid hormone levels down to normal, and then have the RFA done, to
Gotcha.
protect against thyroid storm, because thyroid storm can be fatal. So it's nothing to take lightly. And just because you're in the clinic doesn't mean it can't happen. So we always make sure that we treat people for their hyperthyroidism before we do their definitive procedure to get rid of their hyperthyroidism.
Gotcha. That makes complete sense. I really like how you explained about squeezing the thyroid. It makes me think about like squeezing a lemon, and you squeeze it and the juice comes out. I imagine that's kind of what's happening in that situation. So thank you for explaining that. Let's see, we've got another person who's asking, is there a limit to how many RFAs can be done and an amount of space between each procedure?
Oh, good question. So we know that for most people, you can have changes in the thyroid that go on for at least 6 months. If, for example, you need to do a second procedure on something like you had done, you want to wait till that first one has taken full effect. Ablated tissue doesn't really ablate again.
Okay.
It's kind of scarred in there, and it's fibrous. There are changes in it, because when you ablate tissue, you actually kill those cells.
Right.
Now, some of that gets reabsorbed by the body, the fluid portion, but some scars in. And you want to wait till that scarring process, that shrinkage process is completely done before you would touch up or go back in. You want to wait. And I know people don't like to wait. They want things to shrink instantly, right? But in the end, it will be safer and more effective to have that first full effect done before something else is done again. Now, can you have 8 RFAs in your lifetime? I don't know why you would need that, but from what we know, yes, you can. The beauty of RFA is that the damage is occurring right at the tip of the probe. Since you wouldn't be re-ablating tissue that's already dead and had been ablated, it's not like a radiation exposure like you would have with radioactive iodine.
Right.
Where there's accumulation in there and there's a cancer risk when you do RAI. None of that is true for RFA. Right? And it's also not like CT scans or x-rays where it accumulates in your
And I think too, as you said, the beauty of it is that I know there's a limit to how many neck surgeries someone can have. And after a certain number of neck surgeries, it becomes dangerous. And so, that's another pro, I guess, that you could have, if you need multiple RFAs, you could have them, but there's a limit to the number of neck surgeries.
Yeah, so the problem with the neck surgeries are that anytime you go in, you separate layers that are connected by this, what we call fascia. And it's the things that allow things to slide smoothly, right? So that when you swallow, your whole skin doesn't pull up and down, right? But you get scarring and adhesions in the neck, and when you go in the second time, things are more dangerous. The other thing in particular for cancer, and this plays into RFA, is that we'll take out all the lymph-bearing tissue in the neck if there's metastasis there. Well, the only thing we leave behind are critical structures. Carotid arteries, vagus nerves, maybe jugular veins. And then if there's a node that pops up there that has recurrent cancer in it, going back where there's only scar tissue and critical structures is a much higher risk. And so RFA has been used to ablate small recurrences in an area where surgery would be high risk. So, and we've done that on a couple of very selected patients who know that it's not FDA approved for that, where we talk about where it's been done under research protocols and what the results are. What are our expectations? Is it an expectation for a cure? Because it's likely not to be a curative thing. It's more like a control thing. So these are long, hard conversations that more times you go into a neck, the higher the risks become.
Right.
Especially if there's radiation involved too.
Yes, of course. Yeah. I know a lot of patients are just so eager. I know you said in your experience that patients come to you mostly when they feel like they've got this issue with their throat, but less often for just wanting to preserve the thyroid. But it's actually interesting in my group, that's the main reason people say I don't want to have my thyroid taken out. I want to keep my thyroid. It's so important. And it's like just somehow they just know it's not something they want to lose. And so I'm so excited that this is available now and that it's more common. It's still, we've got a long way to go before it becomes very common and standard of care, but it's just so exciting to me, from the standpoint of when I started this journey myself in July of 2019, there were 2 doctors that I was able to consider, and now there are almost 70 in the US. So I'm just so thrilled about that, and I'm so thankful for all the work that you're doing to help patients with this, and I've heard so many wonderful things about you from your patients.
That's kind. Thank you.
So thank you for doing this interview with me today, and just for people who might be interested in connecting with you, what's the best way for people to find you or connect with you?
I have a website, thyroid.doctor. So that's an easy way to do it. I'm with Advanced ENT and Allergy in Louisville, Kentucky, so that's easy to find on the web as well. And either one of those ways is very, very easy. I have just a couple of videos on this on YouTube, and I always answer all of my RFA questions. I don't answer some of my other videos. I don't answer all the questions on because it's gotten ridiculous. But I have a passion for RFA, as you can tell, and so I've been very keen on getting to those answers, even on my YouTube feedback. A lot of people want to use some of my other YouTube videos as a doctor, like free medical care, and they'll list whole sorts of things, and that's not what it should be for, right? It's just for general education. And
absolutely,
I'm a firm believer that you've got to sit down and talk to the person about your particular situation. You cannot say, well, gosh, Jen on YouTube had a great experience. It may be totally different.
Right.
So what you're doing is great for education, and I love what you've been doing. But when it comes down to it, it's a personal conversation.
Absolutely.
Humans and Hondas are not the same. It's there's a complexity difference there that's just not the same as what kind of brakes do I put on my 2018 Accord, right? It's so much different, and so educate yourself well on YouTube with videos and information, and Facebook groups like you have are terrific for sharing, but ultimately it has to be that one-on-one conversation about your specific situation, because as long as I've done this, and let me just say thyroid operations, because I've done thousands and thousands of those. I haven't done thousands of RFAs yet. They're never the same.
Yeah.
They're never the same. And thank God for me, they're not, because I'd be bored with it for all the thousands of things that I've done. But it's the people that make it different, and every situation is unique. It's one of the reasons I feel blessed to have the job that I do. Is that 25 years into this, I'm still very interested in what I do, and things like RFA just improve what we can do to help people with the issues that they're facing.
Well, I agree 100% with that. It's very important to me. I always make sure people understand you have to educate yourself and be your own advocate, and you need to consult with multiple doctors and ask them what they think, and then ultimately you have to decide what is the best course for you personally. I always make sure people understand, I'm not a doctor. I am not a thyroid expert. I can tell you about my story, but ultimately the decision falls on you and your doctor together. So
let me throw one more thing in there. You made me think of that. Sometimes people will come in with a list of questions that they should be asked, and I would say if you have people who are interested in RFA, they should not ask about RFA. They should ask their doctor or whoever they're consulting with, is there any way to non-surgically shrink these nodules? And if they don't know RFA, then you need to move on.
I see what you're getting at. Okay, don't put the words RFA out there.
No.
See if they bring it up.
Because a long time ago, there was this thing called a partial tonsillectomy, okay?
Okay.
It's a great procedure. It's a great option in some sort of situations.
Mhm.
But I see the same thing happening with RFA. When doctors don't know about it, and you say, well, what do you think of RFA? And, oh, no, you don't want to have anything to do with that.
Yeah.
They don't know about it.
Yeah.
They don't know about it.
Absolutely.
So not naming it, it's just one of those quiz things. Like, let's see if they're aware. Let's see if they know. Or is there any non-surgical options for shrinking my thyroid nodule?
Mm-hmm.
And if they don't say, well, there's two. There's RFA and there's laser. If they don't know, then you're not going to get the answers you need to really know whether RFA is right for you.
I think that is an excellent piece of advice.
Yeah.
Thank you so much for that, Dr. Forwith.
And
love
by the way, I'm an enthusiast for RFA, but there are people, and I've had to tell them, no, it's not for you. It's not right for you.
Right.
You need the second biopsy, and I can't tell you how many second biopsies have come back as not benign. And we've had a handful of cancers because they wanted RFA, and we had some extra testing. When you have a big nodule, sometimes it's not all the same, and so that biopsy needs to be done from the most suspicious part.
Yes.
And if they just tested the benign looking part and they didn't test that little nest that looks bad in there, you may not have an accurate biopsy. So I had one that came a long way with 2 needle biopsies ready for RFA. And when I looked at it myself with the ultrasound, I'm like, okay, we know this has been growing, but the pictures help, because I put the picture on the screen and I said, look at how normal and benign this looks, and look at this area right here. Sure enough, that was a cancer.
Wow.
Yep, came from hours away, wanting RFA. 2 hours, just a couple hours north of Indianapolis, but there was a cancer growing there.
I think that's reasonable, to turn someone away when you see those things. And I think the most important thing for a patient and a doctor is that that you don't rush into anything. The first time I saw a doctor for my thyroid, he's like, let's just cut it out. And I'm like, but we haven't even talked about this. Like, why is it here? What caused it? What else can I do besides cut it out? He didn't want to talk about all those things. And I think, unfortunately, there are a lot of doctors who let's just cut it out. And so even in those cases where the patient is not a good fit for RFA, at least when they've pursued that option all the way to the point where you tell them it's not a wise option for you, at least they can know going into their surgery, I did the due diligence and I know that I'm doing the right thing.
Yep. I love to use the phrase that if I'm doing my job right, a second opinion makes me look good, right? I mean, you go see another doctor and they say, well, this is what I would do, and it's the same as what I had recommended. That makes me look good. And if I don't have the confidence to allow for that, that's a red flag that maybe I don't have the confidence to advise you well either. Right? Now, with RFA, some people won't know about it. And so they'll say, well, I talked to my doctor and they were really worried about the RFA. I'm like, let me know who they are. I'd be happy to have a conversation about this. Right?
Oh, that's amazing.
I'd be happy to help educate, because at least they're honest enough to say, I don't know. I don't know enough about it. But we have a huge body of literature for RFA. We have a huge body of experience, and yes, it is from other countries. We don't have a huge body here in the US yet, but we're accumulating it. But there are really good doctors like Dr. Rangel who've been doing this for a long time, and I would totally trust him. I was in Brazil. I spent some time with him, and I even have the nice ability to text him. Right.
Oh, wow.
What do you think of this? Would you do this or would you do that? And even though, like I say, I've been in practice 25 years, he's about my age, but he's been doing RFA a lot longer than I have. So it's good to have that sort of network where we can share experiences. And this is why we have person-to-person meetings after COVID is done, hopefully again, where we get to talk about these things and in a forum that allows for ideas and for progress to be made. More people, once we get through COVID and we can have more face-to-face meetings and people can hear from people like me who've done it for a while now, it's going to grow. It's going to grow rapidly. But I was supposed to teach 3 different courses that were canceled because of COVID.
Oh,
yeah.
Wow. I'm so sorry that didn't happen, but I'm excited to know that that was on the table, you know?
Yeah, it'll catch up. It'll catch up. So I think this will grow pretty quickly, but we just got to make sure that people do the right things and don't knock people out for this procedure, and don't give up our safety margins.
Dr. Forwith, this has been an absolute pleasure for me.
Very good.
I really, really appreciate your time and all of your very thoughtful answers, and I'm just so glad to meet you and get to know you. This has been wonderful. Thank you so much.
Oh, you're very welcome. Very welcome. Thank you for what you do. This has been fun to talk with you as well.
I know this was a long video, but thank you for hanging in there to the very end. I just didn't want to cut out any of Dr. Forwith's content because it was so good. So if you made it this far and you liked it, please give this video a thumbs up, and please subscribe to this channel because it really helps YouTube put this video in front of more people, and that helps to educate more people about the fact that they can save their thyroid. Don't forget.